Yes, welcome everybody. It's so great to see you on this wonderful, starting to feel like early fall day here and looking out. Nothing has quite changed yet, but it's certainly beautiful. And some of us needed an extra blanket last night, so that's how we know it's coming. We're very excited. Um, there's been many people that have signed up for this, and that's for good reason. The topic is which vaccine should you have and why? RSV, COVID, influenza, and pneumonia. Everybody is as confused as you are. And so we're going to have a Dr. Camille Kotton, who will be introduced in a moment, to help us work through all of this because this is very confusing, even for those of us who are telling you what to do. So I'm going to pass the baton to Susan, and then Dr. Cotton will help set us right.
Thank you, Dr. Levine. So welcome, everyone. My name is Susan Edgman-Levitan, and I'm the director of the Stokel Center for Primary Care Innovation in the Division of General Internal Medicine at Mass General. So before we get started today, I want to go over a few background sort of in housekeeping information that will be helpful, I think, for today's call. So the first thing I want to mention is that we mute all of you. The only people who aren't muted are the speakers, and that way we can eliminate any background noise that may arise or may even surprise the person who has background noise. So we cannot hear anyone talk. You can view the speaker on your full screen, or you can go to the gallery view in the upper right corner of the Zoom screen. Click on that, and that way you'll be able to see all the participants. If your picture becomes jumpy or out of sync, click Stop Video in the lower left-hand corner, and it's a little video camera, and that will help speed up your internet connection. For questions today, and I suspect we're going to have a lot of questions, please use the chat feature, which is right in the middle of the bottom ribbon across your screen. But we do want to make sure that everyone knows that anything you write in the chat, everyone on today's town hall can see it. So we really want to make sure that you don't put in any personal medical questions or information because everyone will be able to see what you've written. But if you do have a medical question, please reach out to your doctor directly. We're covering a lot of information today, but the town hall recording will be available on the MGH YouTube site and on the Geriatric Medicine site. And we also make these available on some of our primary care websites. So again, please put your questions in the chat and I will be going through those and we'll tee those up for Dr. Kotton. We are very grateful for Dr. Camille Nelson Kotton to be with us today. And she also happens to be in Brazil. So she is very committed to educating all of us. So Dr. Camille Nelson Kotton is the clinical director of transplant and immunocompromised host infectious diseases in the infectious disease division at Mass General Hospital. She's an associate professor at Harvard Medical School, and she is also a voting member of the Advisory Committee on Immunization Practice for the CDC, and she is the chair of the Adult RSV Vaccine Work Group. So with that, I'm going to turn this over to Dr. Kotton, and let's get going. I know we have a lot to cover today.
All right, so I love talking about vaccines. Nothing in medicine has saved as many lives as vaccines. And it's a really great time in the vaccine world because we have new things and wonderful ways to prevent vaccine preventable illness. Thank goodness. Okay, so first of all, what is the background here and how do things evolve? So what happens in the United States is that first, the Food and Drug Administration approves a certain vaccine. So we can't do anything until there is FDA approval, whether it's emergency use authorization or standard approval, but the FDA approves a vaccine, and then the CDC Advisory Committee on Immunization Practice makes recommendations for implementation of the vaccine. It's interesting. We are 15 members on the Advisory Committee on Immunization Practice, and we actually are separate from the ACIP. So we are not, I'm sorry, we are separate from the CDC. We are not CDC employees. We're actually paid a very small stipend, but through an organization. And people think that these recommendations come from the CDC. It's actually from an external body of people who are involved in public health and all kinds of issues. We make a recommendation to the CDC, and usually the CDC really want to get down into the weeds. All of the vaccines that we ever talk about are available on this ACIP meeting information site. You can attend live meetings. We have one tomorrow. We're going to talk about maternal RSV vaccines, or pregnant people RSV vaccines. It's an all-day extravaganza. Anybody that wants to listen for 7 or 8 hours is welcome to. Any of the slides you want, everything's fully transparent. So it's pretty cool. Every year, the CDC makes recommendations for adults, and you can see in this slide all the different age cohorts across the top, and then all the different vaccines. And the yellow ones are recommended for everyone. Purple is if there are risk factors, etc. So I won't go into those details now. And then we also have recommendations that are made based on specific things like pregnancy. I usually focus on this immunocompromised, as outlined in red. People who have kidney disease, liver disease, heart disease, lung disease. Everybody needs specific vaccines based on specific criteria. And again, this is updated every year. And this is very easy to find. If you Google CDC adult vaccine recommendations or ACIP adult vaccine recommendations, you can quickly pull this up. So let's talk first about COVID vaccines. I do want to highlight that we've had a pretty good summer with respect to COVID. We look at wastewater data. Probably many of you are familiar with this. We look at wastewater data as a way to portend what's happening with COVID. And you can see here, this is from Massachusetts, and this is the North Shore, and this is the South Shore. You can see that over the summer, say from April through July, we had really low disease rates. But sort of about since July 1st, rates have been creeping up, which is a little ominous. Almost for sure, we will never get to where it is on the far left, which was Omicron. We will not get there, but there will be ongoing ebbs and flows. So it seems like it's a good time for a vaccine. People say like, oh, you know, what good is it? I already had two doses, 3 doses. Do I really need any further vaccines? And I thought this is a nice graphic. This is Dr. David Boulware, who is very well respected in the infectious disease world. And he published this information looking at adults aged 30 to 85 who basically were just overweight or obese. And how much did a booster help them? Well, no vaccine resulted in much higher rates of symptoms. Having a primary vaccine series, you know, way back in 2021, resulted in lower symptoms, but people who've had boosters overall have much lower rates of symptoms, lower rates of long COVID. And so this is the type of thing that makes us say, let's all stay up to date with our vaccines in order to eliminate or markedly decrease the risk of symptoms when and if we get COVID, and then also decrease things like long COVID. So we just had a meeting last week where we made a recommendation to have everyone who's 5 years of age and older to get a dose of the updated mRNA COVID-19 vaccine. So there's a new vaccine on the market. We previously had the bivalent vaccine, but that's actually no longer FDA approved. It's gone. It's taken off the market. I've had people asking to get it. It can't be gotten. It's done. So bivalent is old. we're not using it anymore. And so what is now available, and it's really kind of emerging. I think that many pharmacies are getting it like just this week. But so everybody, it is recommended that everyone get 1 dose of the updated mRNA COVID-19 vaccine. For people who are moderate or severely immunocompromised, there is a recommendation that they can get a second dose at least 2 months after the first dose. But in general, for my immunocompromised patients, I'm recommending dosing every 6 months. We don't have an updated recommendation for people over the age of 65 yet for this, but keep your ears tuned. It's an ongoing process. It'll depend on what we see for vaccine protection and then disease rates. So common questions I get are, what if I've had recent COVID-19 infection? So most of us say it's very reasonable to wait 3 months for the vaccine. It's not a safety issue if you get it sooner. It's just not really necessary because you're probably protected by having had recent infection. What if someone had the bivalent vaccine a month ago? Well, reasonable to wait 3 months for the new vaccine, not a safety issue if it's given sooner. What if someone had no prior vaccines? We actually still are seeing these people. 1 dose of the new monovalent XBB vaccine is recommended. And then there's a great website that's the link is there, and I'm happy to share these slides. But that covers many, many questions. And then what about cost? So this is the first time that the vaccines are being covered by private insurance. My understanding is that they have been told to cover this, and there should not be problems with that. And then there's a wonderful program set up by the CDC and Health and Human Services called the Bridge Program, which is for uninsured or underinsured to aim for what's called immunologic equity, so that everybody has access to vaccines, whether or not they have adequate insurance coverage. Okay, let's move on to RSV vaccines. So lots of questions here. First of all, RSV. So RSV can cause a good number of hospitalizations among adults over the age of 65 in any given year in the United States. We have not been doing a lot of testing for RSV, so a lot of people don't really know about RSV, but in the past 5 years, we've started to do a lot more testing. It is estimated that there are 60 to 160,000 hospitalizations per year among older adults, and that there are 10,000 to 14,000 deaths per year among adults 65 years of age and over. So we do see a good amount of disease, hospitalization, and then long-term effects where people sort of have almost long RSV, but like feel poorly for quite a long time. If you look at this figure at the bottom, you can see that RSV in most years sort of happens in October, November, December, really peaking a little earlier than we usually see influenza. But in 2021, 2022, it actually happened earlier. So we never know when it's going to happen, and that's why the recommendations would be to get your RSV vaccine. If you're going to get an RSV vaccine, go ahead and get one. Don't wait for disease to happen. There are no antivirus treatments like there's for COVID. We have Paxlovid and Molnupiravir and Remdesivir. For RSV, we don't have anything. So there are 2 new vaccines on the market. The bottom line is, I think that both vaccines are very, very similar, and I think you can go with either one and get whatever is available to you at your local pharmacy. Both of these were in very large clinical trials where they randomized people 1-to-1 to either receive the vaccine or placebo. And then they saw that the people who got vaccine with what's called the GSK vaccine, they had protection against disease, against significant disease at 83% the first year, 56% the second year, and overall 75% rate of protection. So that's really quite good. What was interesting is they didn't, and that was similar for the Pfizer vaccine, where it was about 84% protection across the first 2 seasons. So those numbers, 84% might seem larger than 75%, but realistically, they used somewhat different endpoint definitions. And in general, these numbers would be, statistically speaking, considered about the same. With GSK, when they gave a booster dose, it was interesting that they didn't see an impact from giving the booster dose. The GSK vaccine contains an adjuvant, which is an immune stimulant that is half the dose, but the same adjuvant as that is in the shingles vaccine. In general, both of these were well tolerated. There were a few people who got vaccine in each arm who had new onset atrial fibrillation. And then of many tens of thousands of people who received the vaccine, with GSK, there was one case of Guillain-Barré syndrome and 2 cases in the people who got the Pfizer vaccine. Now, Guillain-Barré syndrome is when people have a neurologic condition where they develop weakness, usually in their feet, and it kind of ascends up it climbs up their body. It's usually reversible. It's interesting. It's a curious disease. We do see it with things like Campylobacter, that's a foodborne bacteria illness. And just in general, people over the age of 65 who were in these clinical trials are at higher risk for getting Guillain-Barré to begin with. These rates overall are very low. We're not sure that it's from vaccine versus just that it's a very well investigated population. I will say that we do see Guillain-Barré with other vaccines, and with seasonal influenza, it's about 1 to 2 per million doses of influenza. And with Shingrix, it looks like we saw about 6 cases per million doses of the shingles vaccine. So very low, not zero, but certainly when you think about the overall risk of developing these life-threatening and what can be life-threatening or very disabling infections, we think that the benefit of vaccine greatly outweighs this risk. So RSV vaccines are currently, for people over 60 years of age and over, have shown moderate to high efficacy in preventing symptomatic RSV, lower respiratory tract disease among infections over the age of 60. And in June, we voted that people over 60 years of age and up can receive a dose of vaccine using shared clinical decision-making. Now, what does shared clinical decision-making? That means that we don't recommend it for everyone 60 years of age and over, but to talk to your clinical team. And that might be a doctor, a nurse practitioner, a physician's assistant, your pharmacist, other people who are involved. And it just means talk it over and be sure that this is the right choice for you. Now, who should get this? So this is a list of people who are at increased risk for severe RSV disease. And you'll see that many people 60 years of age and above have these conditions, which include lung disease, heart disease, people who are immune compromised, people with diabetes, people with neurologic or neuromuscular conditions, kidney and liver disease, blood diseases, and then also people who are frail, people who are 75 years of age and over, or people who live in a nursing home or a long-term care facility. So you may wish to talk to your clinical team about whether this is recommended for you. So why shared clinical decision-making? Why did we not make a universal recommendation? Well, when they did the trials, unfortunately, they kind of ended up enrolling in the trials a lot of relatively healthy people in their 60s. So we had hesitations about what that meant for people who were frail or older. There was some concern about what we would see with neurologic events, although again, those were at very, very low signals. Some concern about new onset atrial fibrillation, although those numbers were very small, like a couple of cases per over 10,000 patients. Also, they didn't include immunocompromised patients, so it's hard to know what recommendation to make there, but this RSV can be devastating, and I've actually had many patients die from RSV when they're immune compromised. And because these studies were unfortunately done during the pandemic, a lot of people were wearing masks, so they ended up having very low rates of hospitalization, very low rates of death. So it's kind of the medical data we got from the trials was a little bit stymied by the fact that everyone was wearing masks and separating and practicing good infection control. And we also had some concern about the lack of a booster effect with that was seen with GSK vaccine. We don't have data yet on the Pfizer vaccine. So currently it is approved and recommended as a single dose. It is recommended that RSV vaccine be given before RSV activity picks up in the community. And just be careful because the seasonality of RSV can really change year to year. And we think that COVID has kind of messed up where the other viruses are standardly occurring. And recommendations are that it can be given with other RSV vaccine can be given with influenza, COVID-19, other vaccines. So if you need to, you can get all the vaccines at once. Now, the real explanation there is that the CDC is in the business of keeping America healthy. Okay, so that's public health. So for some who don't have easy access to vaccines or who might just have one opportunity to get vaccines, either, you know, they work long hours or they live on an Indian reservation or are very far away from healthcare, it is recommended that they get, you know, as many vaccines as they can rather than missing out on the opportunity to get vaccines. Now, my take is that if it's no big deal for you to get multiple, to go back to CVS, Walgreens, your primary care doctor, wherever it is you're getting vaccines, if it's no big deal, you could kind of separate them out by a week or two, and you might feel a little better. But if you are kind of like sick and tired of getting vaccines, you could also just get several at once. So it's kind of a personal opinion. We don't think that there's any harm. It is recommended by the CDC that you can get multiple vaccines at once, and it's sort of in the category of personal preference. Prior to the pandemic, we standardly gave many vaccines all at once in infectious disease clinic, and it's only really been a post-pandemic phenomenon that we've separated vaccines or had any kind of vaccine hesitancy. Now, cost with RSV vaccine is a big deal. And this is the American healthcare system at its finest. So I will tell you that initially the vaccine makers said the vaccines would be somewhere over $100 to $150. And at the very last minute, just before we voted on a recommendation, they doubled the price to close to $300 each. And I will tell you that at the national meeting, I had quite firm words to say to them about that, because it seemed like they were finding an opportunity to increase the price at the last minute. Nonetheless, they're about $300 each plus administration fees. So if you have Medicare Part D, this will be covered in full. I have not heard about any problems. The Inflation Reduction Act has ensured that people who have Medicare Part D will get vaccines covered for free. So Shingrix is free, other things are free if you have Medicare Part D. Now, if you're not on Medicare Part D, then it gets pretty messy. Under federal policy, private insurance has a year or longer to determine coverage. And so many of the private insurers have not covered this yet. And I'm hearing about people going to the pharmacy and being told it'll be $350, $400 for vaccine plus administration fee. And this is not the CDC. This is Health and Human Services. This is a federal policy. It's been in place for a very long time. There is a lot of discussion going on about how that policy is really not tolerable in the modern era. So there are people that are trying to fix it, but certainly if you want to get the RSV vaccine, by all means, ask what the cost is, and that may enter into your shared clinical decision-making. And just to highlight, because there's some confusion, so there are additional RSV vaccines out there. For newborns, there is a monoclonal antibody that they would get injected right at, so RSV is the worst, it's the worst disease for little kids in that it's the #1 reason to be readmitted to hospital in that first year of life. So we have a monoclonal antibody they can receive at birth, and that should be protective for many months afterwards. We also have a pregnant people RSV vaccine that's given near the end of pregnancy. And this is the first time we've done this. But basically, the pregnant person develops antibodies, which are then transmitted to the fetus. And that's another way to protect the fetus against RSV. So what's interesting in speaking to this audience is that both of these may decrease disease in early childhood populations, and that may then decrease spread to older adults. So for all of you that are babysitting your grandchildren, et cetera, these vaccines, certainly for those newborns, maybe, we don't know, but may be protective for older folks. And what is the future for RSV vaccines? Well, Moderna has an mRNA vaccine that seems to be likely to be on the market within the next year. There was a press release that showed very good vaccine efficacy. There have been other companies, Janssen and Novavax, who've stopped development of their RSV vaccines. Basically, they didn't look as good as what's already on the market, so I think they stopped. We will soon review data on the use of these vaccines in people who are 50 to 59 years old, but it's not yet approved for that population. There will be data on additional booster doses, and then we are going to be doing a lot of surveillance for neurologic conditions, atrial fibrillation, et cetera. And so there will be a lot of what's called post-marketing monitoring, and there will be reports that go to the CDC and then VSafe. And for any of you that are interested in contributing to medical science in a really easy way, I don't know how many of you did VSafe for your COVID vaccines, but starting in early October, if you get an RSV vaccine, you can use VSafe, which is, so it comes to your smartphone. I would get a text link and I would enter how I was feeling after my COVID vaccine. And it's a way to add very easily, just like a couple of ticks on the phone, to add to our national knowledge about vaccines. There have been a lot of statements about, we don't know about these vaccines, this is new, all this stuff. But honestly, we have more medical knowledge about these vaccines than pretty much anything ever in the medical field. We know a lot more about these vaccines than aspirin or Tylenol. But if you want to contribute, VSafe is a great and easy way to do it. And it actually really works. One of my colleagues was doing it and she entered some data, and the CDC called her that day to talk about her health issues, which turned out to be not related to vaccine, but she was really impressed with the way the system works. And we at the CDC really rely on this data. So we will be very appreciative of all the information we have. Just quickly on flu shots. In any given year, we do see a lot of influenza activity, some years more than others. Usually we sort of see it, I always think it sort of picks up right around Christmas and into New Year's, right when we're having all those parties and everyone's swapping viruses. And then we have pretty robust influenza. The influenza season is usually late December, sort of through April. Which is why we don't recommend that people get a flu shot in August, in that it can kind of peter out for coverage. We do recommend that people get it in either September or October. And we recommend a flu shot for everyone. There's some pretty cool, if you really want to get into it, I personally love maps and data. So there's this influenza, you can trend the influenza disease activity map. I just copied this yesterday, but you can see that already in Texas and then in the District of Columbia, we're starting to see moderate amounts of influenza. This is pretty cool if you're traveling or if you just want to think about like inviting relatives over or, whatever. It's pretty cool. This map changes colors pretty dramatically. I love trending the map. And you can get this through a quick Google search. Just if you put CDC influenza map, you should be able to pull this up real quick. So the current vaccine is recommended for everyone 6 months of age and older. It is a quadrivalent vaccine now. So we used to have 3 different strains. Now all the vaccines have 4 strains. And for people 65 years of age and older, we have various vaccines. Some of them are higher dose. Some have an adjuvant, which is that immune stimulant to make the vaccine effect work a little better. But there are a lot of lot of vaccine choices out there, and basically I think they're all good choices. This is a detailed list. I personally find this a little overwhelming. The ones that are recommended standardly for people 65 years of age and over are either the high dose Fluzone or the adjuvanted Fluad. But if you go into your pharmacy and say, I want the vaccine for people over the age of 65, they should be giving you that. We have good data that came out of, so every year, influenza circulates in the southern hemisphere for half the year and then the northern hemisphere, and it goes back and forth. Pretty cool. And it's in the tropics all year long. So it does look like the current vaccine that we've picked for this year had really good protection based on data that we got out of South America. So it looks like we have a really good influenza vaccine this year. So either way, we would recommend it, but it's always good to have data suggesting it really is likely to be quite protective. And then there's been a lot of questions about testing. I think everyone's really good with COVID-19 testing. We do it at home, all kinds of things. So if you come into the emergency room at Mass General, and I can't speak for all of MGB because that's complicated, but basically, starting in October, if you come in with viral symptoms, we will test you for COVID, we will test you for influenza, and we will test you for RSV. Okay, so there's a lot that goes into why we test when. We're not testing like flu and RSV all year long because it's not out there. So why send tests that aren't, for a disease that's not around? But so if you do come in, you may have that testing done. And then I just want to briefly touch base on a bacterial pneumonia, so Streptococcus pneumoniae. So Streptococcus pneumoniae is the most common cause of bacterial pneumonia. And this is pretty cool. If you look at the slide on the left, so this is in little kids. We basically introduced this Prevnar 7 vaccine in red. And the red line is strains that would be covered by that vaccine. And you can see that rates really plummeted. So when I was in medical school, we used to see horrible invasive pneumococcal disease. It would cause meningitis in little kids, all kinds of things. It was a horrible disease. And we've pretty much eradicated it in children through the use of good vaccines. What's also really cool is that in adults, when we started vaccinating kids, like this line in red over on the right, when we started vaccinating kids, we really impacted the rates of disease in adults. So that's pretty cool. We initially gave PCV7 to kids, and then we added more protection. I'll show you a slide in a minute, but a broader vaccine when we got better at the vaccine, PCV13, which would be covered. It's this blue line, things that would be covered by that vaccine. And you can see the blue line drops, right? So we protecting kids and adults over the age of 65 benefit. The line in green is things that aren't covered by PCV13. So like vaccines really do work. And when we don't have coverage, we don't get protection. So this is pretty cool how vaccinating little kids really helped older adults. So there is a new vaccine on the market. It's called Prevnar 20. So all of these things are basically just the number of strains that we cover. So we covered 7 strains, 13, 15, 20. That's the number of strains covered. Now, 23 does sound better than 20, but it's not as robust of a vaccine. It's kind of a wimpy vaccine. It actually was the first one on the market. It was developed by Dr. Robert Austrian at the University of Pennsylvania, where I trained, and I had the privilege of working with him. And it was a wonderful vaccine because it was the first one to market, but it doesn't provide robust protection. So the current recommendations are that people get this PCV20, also called Prevnar 20, for the broadest protection, broadest and deepest protection out there. Now, there's a lot of questions. This is a complex slide. Everybody's a little befuddled. But I would say the bottom line should be, if you haven't had a pneumonia vaccine in the past 5 years, go get yourself a Prevnar 20. That's like the bottom line. There's the bottom line. So if you haven't had a vaccine in the past 5 years against pneumonia, either Pneumovax, Prevnar, etc., if you're over the age of 65, go get yourself a Prevnar 20. it's really, this data, it's really nice. I feel honored that we have this opportunity to provide people with such protection. And as an infectious disease specialist, it's actually very rare that I see pneumococcal infections, even though had been one of the most common infections we used to see. So the CDC has some cool apps. They actually have a whole pneumonia vaccine app that I think anybody could download, and you could enter all your data and see what you come up with. And then there's some vaccine resources. This is, if you just want to read about COVID vaccines, this is sort of intended for a medical audience, but people say I'm confused or whatever. This is the website I have bookmarked. I actually have it in my email signature because it's so widely used and people need access to it. But this is the one that's like super clear and great links and really well constructed. And then if you just feel like following, like, hey, what's going on with variants? And I want to know cutting edge stuff. I don't want to follow it in the news. I want to follow it from the source. This CDC website is super cool for if you just want to be like the coolest kid and know all about all the variants and everything. This is that. So in summary, there's never been a better or safer time to prevent vaccine preventable illness. And that is really wonderful and gives me great joy. The best time to vaccinate is when you're thinking about it. Like sometimes people are like, yeah, I'm about to get around to that. In fact, a lot of people that I see with shingles are people that say, oh, Dr. Kotton, you told me to get the shingles vaccine, but I kind of hadn't gotten around to it. And then they feel kind of badly because they're like, oh, this didn't have to happen. So bottom line from all of this, because there's a lot, I just presented an awful lot of information, but pretty much everyone over the age of 65 should consider getting the new COVID-19 vaccine. You can wait 3 months if you recently had infection or you recently had the bivalent vaccine. Everybody should be getting a flu shot. And then everybody should get an RSV vaccine if they have risk factors. So that's for many, not all. Thanks a lot for your attention, and I'm happy to have questions.
Thank you. That was a wonderful presentation, and I'm excited about the apps that you shared with us. I have a question. While you were speaking, I went on to see the VSafe. And there are multiple VSafe apps, and some have a lot of different languages right after VSafe. So I wasn't sure which one to download.
It's not live. It's not live yet for RSV. So we're working on that. I'm told it'll be live in early October.
Okay.
So you should, if you get your vaccine in early October, you should have, somebody should ask you, would you like to participate in VSafe?
Okay.
It doesn't always happen, but it's not live yet, basically.
All right. Thank you. So I think you've covered this, but there was a lot of information here today. So I think one of our first questions was, what order do you do this in? And do you have to wait between any of the vaccines until you get if you're going to get all three, what order, and do you have to stage them, I guess is the best way to put it. And I think you did talk about that, but it probably wouldn't hurt to go over it a little bit again.
Yeah. So I do vaccines. I always say it's like a hand-tailored suit. So depending on when your last dose of COVID-19 vaccine was, if it's been a year since your last COVID vaccine, the thing that's circulating right now is COVID-19. So I would get the new COVID-19 vaccine. We're actually not calling it a booster. It is a new vaccine. So it may boost some of your prior immunity, but it covers new things. So booster kind of implies like, yeah, maybe I need one, maybe I don't really need to boost. No, this is a new vaccine. And I think it is important to get it. So because COVID's circulating now, I'd go with COVID first. And then because RSV usually comes before flu, I would probably, if it were me, I'd get COVID now, wait a week or two, whatever. You don't have to if you don't want to. I'd probably then get RSV. I'd make sure my insurance company is covering it, and I'd want to know the cost and all of that. So I might explore that issue. There's probably no fighting with insurance companies. Like, this isn't going to be like call your doctor and they're going to wave a magic wand. Honestly, if insurance isn't covering it, you can call your insurance company and argue, but it seems like that might not be one of the times that you would win. There was a big article in the New York Times about that, and people who read the New York Times were not able to get vaccines. So that's a pretty, you know, those New Yorkers, right? You know, Yankees fans and everything. They weren't able to get themselves the vaccine. So you might have to wait a year for the insurance coverage to come through. And even then there might be significant cost sharing. You know, that's American pharma. And then I'd probably get flu. So just to summarize, COVID, RSV, and flu kind of in the next month. And then you're like triple protected. You could also get all of those at once. No problem. Like, if you're just done, if you hate going to CVS, Walgreens, the hospital, whatever it is, you're, you know, whatever you want to do. Sometimes there are some caveats, like if you are traveling, good idea to get your vaccines before you travel, especially a COVID vaccine. One thing we know about the COVID vaccines is that there is protection against infection for the first couple of months. So I have an upcoming trip in December. So I'm actually going to time my vaccine before that kind of big trip to the developing world in December, because I really don't want to get sick on that trip. So I wouldn't wait too long. But yeah, so COVID, RSV, and flu. So CRF. I don't have any great marketing or anything for that. CRF, COVID, RSV, flu.
That's helpful. Thank you. By any chance, do you know if Blue Cross Blue Shield of Massachusetts is covering RSV? Does it?
No idea.
Okay.
No idea. Never trust a doctor with money. Doctors, if only they asked us, we would have everything covered. But don't trust a doctor with money. The only thing I can say is if you have Medicare Part D covered, and otherwise we really don't know. And I'm sorry for that. That's part of a big problem with American healthcare.
Okay. Okay. And I see that someone has put into the chat that their daughter and granddaughter already have the flu, as documented by their doctor in Cambridge here in Boston. So another question is, if you've received the first shingles shot, but it's been over a year and you've not gotten the second one, what should you do now?
Just go get the second one, and 2 shots and you're done. That's okay. That's okay. It happens. It's okay. No harm, but you should definitely get your second one, because one alone, shingles is a pretty amazing vaccine. The old shingles vaccine was about 50% protective for 5 to 7 years. The new one, Shingrix, which has been the only one available on the market for about at least 5 years now, is 97% protective for about 18 years. Pretty amazing. Like, I'm seeing so much less shingles. It's wonderful. 1 in every 3 Americans get shingles. We're really knocking that number down. It's wonderful.
That's great. That is great. So I see that Dr. Levine posted something about paroxysmal AFib. Do you want to say anything about that, Dr. Levine, or ask a question?
Well, we have a lot of patients who have paroxysmal atrial fibrillation, and I wonder if they're at any higher risk for getting for developing AFib after getting RSV, based on what you said. Because I think that they'll, I think that they might ask.
Yes.
So the numbers of cases of AFib were very, very low. The majority of people did have a prior history of AFib. I would say, Dr. Levine, that my concern would be is if they got RSV, they might have severe ongoing AFib, like the disease. So the disease is probably worse than the vaccine risk. And given that this is a pretty common situation, I mean, if they had like severe, horrible, life-altering disease, then AFib, then I might not give it. But in general, the risk of having infection is probably worse than the risk of getting the vaccine.
Okay, thank you.
Thanks.
Someone's asked, someone received the new COVID vaccine in May of 2023. And they're asking, is that the most current one, or is the one that's out now the real new one?
Yes, that one is so old, May. That's old news. So it's gone. It's no longer approved. I know these things are like flashing so fast, right? There's a new one that's just out in mid-September, and that is the new one. The old one, it's done. It's pulled off the market. So there's a new one. And so if you haven't had a vaccine within the past few days, you need the new one.
Okay. So someone tested positive for COVID at the end of May. When should they get the new COVID vaccine?
3 months after that. So you're due now.
Okay.
Yep, 3 months.
Okay, great. And someone else has a big trip at the end of February. Should they get the COVID shot now and again in February, or what do you recommend?
So right now that would be off-label, but we are allowed to give extra doses of vaccine if it's deemed appropriate. I suspect that there will be a recommendation for people 65 years of age and over to get another dose of vaccine, but I don't wait until February to get, because you could get really sick. Don't wait until February to get so get a dose now and probably get another dose closer to then.
Okay. And another person has asked if age itself is a risk factor for RSV.
Yes, that is a really good question. People who are 75 years of age and over, it would be recommended for them, because just being 75 years of age, and I know many people are robust and strong and healthy at 75, but we see devastating illness. And so all the medical literature supports that people 75 years of age and over should get the RSV vaccine, even if they have nothing else going on with their health.
Okay. Is there any length of time you should wait to get the vaccines after you've had surgery?
No.
Okay. Okay. And then we have another question about if a person got only one shot of the pneumonia vaccine in 2020, should they get Prevnar 20?
Yes, that is a recommendation. Pneumovax is not adequate. Yep. So the recommendations are to have both.
Okay. Okay. And if you got COVID in the last few months, what would you say is the cutoff of protection with respect to the new variant?
I don't think so probably less. We know that vaccine protection is much better than natural disease protection. Natural disease protection fades pretty quickly. So I would not overthink this. I think we actually have, I don't really need that vaccine, but my job all day, I see all these people that are like, yeah, they didn't think they needed vaccines. And then now the emergency room's full. I was taking care of someone in the ICU and I was thinking, why didn't this person get the vaccine that was recommended? It's pretty straightforward. So if you had disease 3 or more months ago, get the new vaccine. If you had a bivalent vaccine, if your last vaccine was in the past 3 months, wait 3 months to get the vaccine, but then get your new vaccine.
Okay. Okay. I am just looking. I think we have covered all the questions. I just want to give you the last couple of minutes just to say anything else that you really want to make sure we hear and do, I think more importantly.
Vaccines are safe. Vaccines are very effective. Vaccines are like wearing a seatbelt in the car. They're a really good idea. Nothing has saved more lives in modern medicine than vaccines. We can improve our health. And as we've seen, having any one of these infections, the infection alone is bad, but the long-term impact of being sick, being hospitalized, maybe going to a rehab, all of those things could be avoided through appropriate use of vaccines. And if you are interested in learning more about vaccine safety, there are a lot of tools. There are a lot of recommendations through the CDC. I am recommending these for my family, my children, my dad, his partner. I redid my in-laws' vaccines recently. They weren't up to date. So I do think that there's a lot that can be done, and that we can really improve the overall health of ourselves, our loved ones, and just all of us as a community.
Great.
Thank you.
And I just have to thank you because you're giving the Stokel Center seminar tomorrow for the Division of General Internal Medicine that I'm going to miss because I have to be at a meeting. But I know people are really going to benefit from that. So thank you. And I am going to ask Dr. Levine, and I'm not sure if Dr. Russell is still with us, if you want to make any closing comments.
I can just make a logistical comment, and I think this is really important to understand, especially for our geriatrics patients. We are, as a physician, I'm a member of a team, and I really want to encourage you to form a relationship with your pharmacist at your local pharmacy, because a lot of these vaccines we don't keep in our office because of storage concerns. And also because of payment concerns. For example, the tetanus booster, there is a $160 copay if we give that to you in our office, whereas you get it covered by Medicare D in your pharmacy office. Some of our patients say, oh, well, I only want to get my vaccines at Mass General. We don't have a special sauce. It's the same vaccine, and we encourage you to get it at your local pharmacy and know who your pharmacist is, and have a discussion with them, especially around the RSV vaccine.
Hey, Dr. Levine?
I think the pharmacists are great. They have been giving zillions of vaccines in the last several years since COVID came around. Every time I go there, I'm very happy with the job that they've done. And and in our office, as Matt said, we don't have a lot of the vaccines because they need to be refrigerated or other reasons. And so I think the main thing is to check your insurance for RSV, it sounds like, more than anything else, from what you said, Camille, right?
Yes, I will say Matt's point's really well taken about vaccine coverage, and we are really struggling with who's paying for what and coverage, and it is kind of ridiculous that I can't give a tetanus booster in my office and I have to send people to CVS, but like rules are rules. And so we've positioned the commercial pharmacies to be quite able to give a lot of these vaccines. So I agree with getting them. Yeah, people do say that all the time, like I want my tetanus vaccine with you, but they're really all the same. I go to CVS. It's also easier. And they've actually done a lot of really good work during the pandemic, saving lives.
Yeah.
I do think that all of you will have questions. This was a lot of information, even hard for us to, digest all of it at once. But the important thing is to get vaccinated, and unless you have a reason why you cannot. And I think this was very complex information given to a lot of us, and it's I think the CDC website is good. I'm going to download your little app that you had, because I think I will use that a lot. And I think it's fabulous that you were able to come to us from so far away. It's a miracle of modern medicine and transportation.
Yes.
Thank you. And also, before we leave, we've got a couple of minutes. I'm going to ask Judy if you can just say quickly where the recording will be available.
Absolutely. I'll send an email to everybody. The recording will be available on the MGH Geriatric Medicine site within 2 weeks. Okay, takes a little time to edit, etc., and then get it up there.
And not the MGH YouTube site?
We don't do that, but we certainly could. And I think Stokel Center, don't you guys put it on yours also?
Yes, but I think actually the MGH YouTube site is really important because I think a lot of people go there to look for information.
I will write that down and make sure that happens. Thanks, Susan.
All right. Thank you. Well, thank you, everyone. Stay healthy. run right out and get your vaccines.
And wash your hands.
And why?
Wash your hands. Wash your hands. You can never wash your hands enough, in my opinion.
Thank you, Dr. Levine. I think that's good closing advice. And Dr. Kotton, have a great time in Brazil and stay safe and healthy. Take care.
Bye-bye.
Bye-bye.